The next speaker is Dr. David Prezant. He's the Chief Medical Officer for the FDNY. Dr. Prezant has written prolifically about lung and other diseases in New York Firefighters, and we are very lucky and pleased to have him here today.
It's a true honor to be invited to talk here. I know many of you, some I'm seeing for the first time. Thank you very much for the nice introduction and for allowing me to go out of order. I have to go to another fundraiser right after this, so I apologize for having to leave after this. But I did want to come here today because this is just such an important issue. You heard the president of the UFA put his power behind this, and certainly everything we know scientifically, ethically, legally supports this ban. I have no conflicts. I absolutely don't take any money from the asbestos industry. I don't take any money from anybody except from our taxpayers, who are nice enough to fund many of the grants and contracts we have through CDC and NIOSH. Tons of people have helped with this, most at the fire department and at Montefiore Einstein, but many other institutions, NYU, Mount Sinai, Stony Brook, et cetera. But critically important, as I'm going to show you in a few moments, is the support we get from our patients. Not on a slide, but I think really to sum it up, and this is true for World Trade Center patients as well as it's true for asbestos miners in any occupation that has a camaraderie, a brotherhood, a sisterhood. When I see patients, the first thing they ask me when they're suffering from these diseases is, how am I doing? And that's understandable. But without any differences amongst all the people I see, the second question, universally, is how are my buddies doing? How is everybody else doing? And that's the importance of research, of being able to answer those questions credibly. And that's what we've done. So I was asked to talk about screening, monitoring, and exposure prevention as it relates to the World Trade Center, but this would be true for any occupational or environmental exposure, including asbestos. And that is what we've done right from day one, is we set up medical screening, monitoring, and treatment programs. We started treatment right there on 9/11, on day one, because we were there. That's part of our job in the fire department. We had annual medical monitoring set up for decades, but we really improved upon it in 1996 when we added, and a key thing was adding lung function measurements via spirometry, so that we were the only group that had pre-9/11 objective health data because of that decision in 1996 to add spirometry to our annual medical program. And our program was always focused and expanded to be certainly focused on this after 9/11, which is in 3 domains. Respiratory, because I'm a lung specialist. No, respiratory because it's so important. Mental health, because that's also important. And then emerging diseases, cancers, autoimmune disease, cardiovascular disease, that the literature has always said has something to do with occupational and environmental exposures. And we know, as was described by Councilwoman Brodeur, that World Trade Center dust was a tremendous toxic exposure. At the fire department, we lost 343 members from trauma on that day. But as of April, when we closed enrollment in our memorial wall, we had lost 403 members after 9/11 from cancers and lung diseases. And now that number is up to about 410. We know the dust was coated with all of the gases and vapors from combustion, as well as fine particulate matter, which, like air pollution, has its own problems, causing chronic inflammation and diseases. It was coated with silicates, PCBs, PVCs, antimony, aromatic hydrocarbons, pulverized concrete, and yes, asbestos. But what we just heard from Dr. Landrigan, which we need to stress over and over again, is this exposure would have been even worse, all right, if all the floors of those 2 towers had been sprayed with asbestos. Oh, and the photo you see at the bottom right is a firefighter that was intubated several weeks after 9/11, had been working down there every day, without proper respiratory protection. He had a bronchoscopy, which is a tube passed down into the lungs. The lungs was washed out, and these are asbestos fibers, uncoated, meaning that there was an acute exposure to asbestos. How do we reduce exposures? Well, by getting rid of asbestos completely and all of these other toxic chemicals. But we're never going to be able to completely rid ourselves from things that are in the environment that are not healthy. So we need to have respirators. And the firefighters have self-contained breathing apparatus, which is on the far left, but it only lasts for about 20 minutes because it's designed for fires. It's not designed for continuous rescue recovery work that they were doing in those days, weeks, and months thereafter. More easily is a purified respirator called PAPR, high-fast elastomeric respirator that you see on almost the far right, and then all the way to the far right, an N95 respirator, which was constructed essentially to protect from TB, but will protect from many of the particulate matters that you have down there, but not from gases and vapors. So exposure reductions is respirators, it's skin protection, it's decontamination, and it's supervision. And I can't stress that more. It needs supervision. None of this stuff is comfortable to wear. And without supervision, people are not going to wear it. And this is where I, of course, never disagree with NIOSH, but never disagree with OSHA, but I have a sort of different spin on it than they do. Their spin is train, 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 train. I can tell you, this is proof training doesn't work because the fire department trains, 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 all right? And yet, as I'm going to show you in the next slide, most people were not wearing respiratory protection. All of that training is critically important. I don't want to be misquoted that we shouldn't train, but without supervision, it becomes sort of meaningless. And here's the proof of that, all right? So the far blue is no respirator. The next bar is a dust mask, which is useless. And then the next bar is rarely used a respirator while I was down there. And then the yellow bar is mostly used a respirator. You can see on 9/11 that less than 10% of the workforce, after their SCBA ran out, actually used a respirator. And you can see, and this is even more important, because listen, day one, you're there to rescue, save lives. You're just going to run in, all right? But what about in the subsequent days? And now look at the far right set of bars. That is October 1st through the end of the recovery effort. And there you can see that still less than 50% of the workers there, of firefighters and EMS workers from the fire department, less than 50% said they wore a respirator most of the time. They were trained, they were fit tested, there was no problem with supplies. It was all an issue of, are we really going to supervise? So for exposure reduction, we need PPA and we need supervision as well as training. So moving on to screening. Screening, we had already set up our annual medical monitoring and had added spirometry in 1996. It involved questionnaires, which we expanded tremendously after 9/11, blood, urine stored for biomonitoring for future studies, cardiograms, hearing tests, cancer screening, following all of the U.S. Preventative Service Task Force recommendations, as well as PSAs for prostate cancer, physician evaluation, spirometry, chest x-ray. On top of that, certain people got even more extensive monitoring. And this was because they had symptoms or because they were smokers or they had massive exposure or they had abnormal spirometry or abnormal chest x-rays, in which case they would get full breathing tests, chest CTs, methylcholine challenge tests, etc. We also did treatment, we did research tests, we have a serum biobank, and all of this, all right, is in this next slide. All of this is captured in our data warehouse. And you can see that we have maintained, if you look at these blue lines, these two blue lines, and go all the way to the far right, which is current dates, you can see that we have 80% long-term commitment to this program. They keep coming back. So I've been, given the 1-minute timing, but this is the reduction in lung function that has happened over time. So clearly there was an effect, all right? This reduction translates to increased mortality, in other words, increased death rates, all right? But because of the work of reducing asbestos, it is amazing, and because of our work in tobacco cessation, it is amazing that while all cancers are increased, lung cancer is actually decreased, all right, in our World Trade Center rescue recovery workers compared to the general U.S. population. We believe it's because of the great work reducing asbestos and our work reducing tobacco use, all right? We have 28% fewer deaths, 38% fewer cancer, colon deaths, prostate cancer deaths than New York State because of protection, monitoring, early diagnosis, aggressive treatment. When we compare our 5-year survival rates, 86% of our people with cancer are still alive, compared to only 63% in the New York State who are never exposed and not part of the monitoring program. So monitoring works. And then finally, I'll say that we have, as you see with asbestosis, now 24 years later, we are now starting to see pulmonary fibrosis, but it is not asbestos disease for the most part because there has been very, very little pleural disease found on our CAT scan screening. And again, that is because of the work of Dr. Selikoff. Thank you very, very much.
What component of the dust do you think accounts for the fibrosis? Would it have been the highly alkaline cement dust, or what was it?
We have found that our chronic inflammation, when we look at cell culture models, which have been predominantly done by one of the labs at Reinstein, we have found that it's the particulate matter that is, as you just said, the pulverized concrete, the particulate matter, that has been most responsible for the chronic inflammation and for the long-term disease processes that we've had, more so than actually the chemicals that they were exposed to that day.
I have one quick question.
Sure.
What was the UIP pattern on the CT scans? Was there any indication that it could be IPF?
Yes. So IPF, by definition, requires no occupational or environmental exposure, right? Which is weird. It's so weird. So we have been told that we can't, when we sent this in for publication and it was published in Lung, we were told we can't use the word IPF. But yes, it is consistent with UIP. It is predominantly a lower lobe bilateral disease, right? And unlike previous reports, 50% of our people with UIP, interstitial lung disease, have progressed to progressive pulmonary fibrosis. We've had 5 lung transplants for this in the last 3 years. Thank you very much. Very
Thanks,
important
Dave.
question.